Hello, I'd like to talk with you today about the recently finalized CMS interoperability rule 0057 and this rule's requirement that payers implement a prior authorization API by the end of 2026. My name is Michael Lunzer, and I'm the CEO of Itiliti Health. We help health insurance companies streamline and automate their prior authorization processes. The result of our work with health plan clients is an improved experience for members and providers, and at the same time decrease cost and faster turnaround times in the prior authorization process for everyone. The Itiliti Health solutions were inspired by work that was being done at a major Blue Cross Blue Shield plan in the Midwest. Itiliti Health was born out of that organization, and this sponsoring health plan, along with our other health plan customers, continue to be a driving force behind the requirements for products that Itiliti Health offers. Over the next 15 minutes, we'll discuss the prior authorization digital interface required by CMS 0057 and the Itiliti Health pathway that our clients have followed to begin meeting the new rule while also decreasing prior authorization costs by about 30% and achieving very high levels of satisfaction from their provider and member partners. The CMS prior authorization rule has divided the prior auth transactions into three specific entities. The first of those is called Coverage Requirements Discovery. It helps to answer the question, is a prior authorization required? The second transaction is called Documents, Templates, and Rules, and it helps the provider to know what do we need to submit, what are going to be the clinical criteria for this prior authorization request. And the third transaction is called Prior Authorization Support, and that transaction governs the rules about submissions and responses to prior authorization requests. Today, most health plans utilize spreadsheets and PDFs to communicate their prior authorization requirements and medical policies and clinical guidelines. As you might imagine, that's not going to work real well when the provider's EMR is sending over a transaction, a digital request to the health insurance company. It's not very easy for them to connect a spreadsheet or a PDF to that transaction. So what's really going to be needed is a comprehensive rules database or application that can store the health plan prior authorization rules and answer that question from the provider's EMR. Similarly, there needs to be a medical policy database application that takes that PDF of a medical policy and breaks it down into separate entities so that it can more effectively answer that question of what are the rules and what are the specific things that need to be submitted in a format that DTR transaction can utilize. The last transaction, prior auth support, really needs a tool that helps the health insurance company make a decision and compare the medical policy requirements to the actual medical record of the patient. For today's conversation, we're going to really focus in on the coverage requirements discovery element of the prior auth transactions. This transaction has essentially a requirement that we're going to answer the question of, is a prior authorization required? The real challenge, though, comes from the fact that these rules change and vary for each health plan by line of business, within the different products that the health plan offers, and are also governed by numerous other factors. Maybe whether or not the provider is in network or the provider is gold carded. These rules also change throughout the year. So they don't always change at the beginning of the year, so it's not possible for the health plan to just publish one set of rules. They need to change rules for each individual entity throughout the year. So the real question then is, a yes/no answer really enough? If we just tell the provider yes or no, a prior authorization is required, does that give them enough information to be valuable to them? So we're going to shift gears a little bit and talk specifically about, how does the provider and payer relationship work today? Why is this is authorization required solution even necessary? The typical scenario today is, once the provider writes an order for a procedure, An administrator at the provider goes to look and see if a prior authorization is going to be needed. When they do that, they typically go out to the health plan website, in which there's maybe a spreadsheet, possibly a 4,000 row spreadsheet with CPT codes and rules that describe whether or not a prior authorization is required for each of those 4,000 rows. There might be multiple spreadsheets on the health plan website, one for each line of business. There might also be variations within that line of business that aren't even put into context on that spreadsheet. Another way that health plans support this requirement is sometimes they'll put very simplistic PA code search tools out on their website, where the provider can enter in the CPT code and get an answer back, yes or no. Again, that doesn't really take into account all of the variations by product that the health plan sells or by date. Another challenge of the tools that payers publish is that they'll put their medical policies out on their website in a document repository and essentially require the provider, if they want to go see what the rules are for a particular prior auth, what the clinical requirements are, they have to go to that document repository and search through thousands of documents, maybe using a general text search to find the right one that applies for that specific date range for that particular member. All in all, these tools are really difficult for the provider administrators to use. And when they're in doubt as to whether or not they're sure they've got the right rules, provider administrators will just pick up the phone. Those phone calls become very cumbersome because oftentimes the health plan call center uses the same ineffective tools. The other option for the provider is just to submit a prior authorization. That way they know they'll be covered in case they've made a mistake looking at those PA lists. So now we're shifting to what does Itiliti Health do to solve this problem? We have a product called PA Checkpoint. PA Checkpoint is a software as a service-based rules database for prior authorization rules. We help the health plan implement their rules into our system, and then we turn over the keys to the health plan to maintain that data. We make it relatively easy. The system supports the ability for the health plan to configure their different lines of business, their different health plan products and rules. Even the carve-outs for specific commercial clients are incorporated into the rules in this database. All rules and medical policies have effective dates, so that it's as simple as the provider entering in basic information to find out which specific rule applies to their patient and their procedure. The PA Checkpoint product is available and accessible through the payer's public website, the payer's provider portal, EMR integrations, and then there's also an administrative portal. So ultimately, we make it really easy for the provider to come in and get a lot of information about the procedure that they're about to perform. The typical PA Checkpoint implementation asks the provider to enter the group number, an optional provider NPI if the health plan utilizes gold carding, the procedure code that they're going to perform, and the expected date of service. When they enter that information into PA Checkpoint, it provides a very comprehensive answer. Not just is a prior authorization required, but also what is the line of business for this patient? Is this procedure code managed or evaluated by the internal health plan, or do they use an affiliated prior auth vendor to make that decision? We also provide a direct link to the medical policy that would apply to this particular procedure, so the provider can know if there are any clinical rules they need to follow that may or may not have been met yet. In addition, we tell the provider if this procedure is considered experimental, are there any special instructions, diagnosis code rules, site of service rules. Numerous other specific instructions can be incorporated into the answer that the provider gets. We can also tell the provider what clinical documentation needs to be submitted, and even if that particular provider is gold carded and exempt from a prior auth because of their performance. As I described earlier, if a provider doesn't have a really good answer that they're confident in of whether or not a prior authorization is required, they will do one of many things. They might pick up the phone and call the health plan. So by implementing this tool, we have seen at our clients that we reduce the prior authorization call center traffic by about 20%. So a really significant reduction in calls from providers. And this can be a pretty significant number. We've seen payers that have anywhere from 600,000 to 1 million provider calls per year. So that's a pretty significant reduction in 20%. Also, we've seen that the call center, the time they spend on calls with providers is significantly reduced as well, because now the health plan call center can use a very efficient tool to get a quick answer back to the provider. In addition, those call centers are now using an accurate tool. In the past, the call center had to use the same tools that the providers did. And so now the call center can use this database to quickly answer the question and do it accurately. At a very small Blue Cross health plan, 140,000 lives, they identified that in the first 4 months, they were on a trajectory to save $3 million in annual clinical costs because their call center had been giving wrong information. In addition to these reductions in call center activity, we've also seen that prior authorization submissions are typically reduced by about 30%. And again, that's because that administrator at the provider has a confident answer and they don't submit unnecessary prior authorizations. So to talk about how this fits in to this new prior authorization API requirement, I'd like to just go back to mentioning that the ultimate goal of these new standards is to get to a scenario where providers do all of their work in their electronic medical record system. There's a FHIR-based connectivity between the electronic medical record system and the payer's system, and these three transactions automatically flow back and forth to achieve an automated answer of whether or not a prior authorization is approved. The challenge that we have, though, is that we know that there's going to be a period of time between now and that future date when all of this beautiful technology is active, where providers are still going to need to be able to use other channels. And Itiliti Health's approach with PA Checkpoint is that our service supports the call center at the health plan if the provider is calling in. We can support the provider that wants to self-serve on the public website of the health plan or through the provider portal. And PA Checkpoint can directly support the provider inside of their EMR using that FHIR interface. As an example of that, just this past January at the FHIR HL7 Connectathon, Itiliti Health and Epic demonstrated connectivity between the Itiliti Health PA Checkpoint product and Epic's system. That means that inside of the provider's EMR, the provider is able to perform their duties normally and get that answer of is a prior authorization required and what are the details without ever leaving their electronic medical record system. The wonderful thing about using this CRD standard to accomplish this task is now when the next customer goes to implement this service, it's already incorporated inside of their EMR in their Epic system, and it can talk directly to PA Checkpoint. The provider doesn't have to leave the EMR, and the PA Checkpoint system receives those queries directly from Epic and responds to Epic. There's really two common questions that Itiliti Health gets asked about this PA Checkpoint product. The first of those is, why can't the IT department of the health plan just build PA Checkpoint? What we have found is that the analysis and understanding the details of the variations of rules that health plans build into their prior authorization processes is much more complex than one thinks when they first look at this challenge. And that means that this system is a pretty complex rules-based engine. Of course, IT departments can build anything, but there are times when it makes more sense for them to buy a component that's purpose-built for a particular challenge. PA Checkpoint is one of those areas. Oftentimes we find that the IT department, when they first look at this problem, thinks it's a simple problem, but once they peel back layers of this, they find that it's much more complex. For that reason, Itiliti Health is more than willing to sell our product as a solution for the health plan, or if the IT department wants to use our database inside of their solution, they can do that as well. Another question that we get from payers is, will this use a lot of internal resources to implement and support? Itiliti Health customers have found that PA Checkpoint is typically about 3 months to implement from the time we get the signature until it goes live. Once it's live, the typical operation means that the health plan has one person that spends 1 day per month maintaining the rules in the system and ensuring that those rules are up to date. Another question we get is, what is the IT resource required to implement this solution? And that's, again, another beautiful thing about software as a service solutions. The product is easy to use. It can support single sign-on, so the IT department of the health plan can support and help to implement that, but it's not required. A Checkpoint product, again, shows up inside the health plan's public website, and that can be as simple as a web page that's developed to talk to the Itiliti Health API. And similarly, the PA Checkpoint product shows up inside of the health plan's provider portal. So it can either be a link inside the provider portal or a custom web page that's designed inside the provider portal to talk to the PA Checkpoint solution. These 3 technical efforts are relatively minor compared to the typical challenges health plans find in implementing technology solutions. So for today, again, we've talked a little bit about the FHIR prior authorization API and the coverage requirements discovery element of the new CMS rules. In future videos, we'll talk more about the documents, templates, and rules, some of the nuances in the ways that can be supported, as well as the decision support applications of Itiliti Health. With that, I'll call our video to a close. I appreciate the opportunity to talk with you and would be happy to schedule a demonstration. Thank you for your time today and have a good day.